This section of the cardiovascular system chapters on the heart is going to look at cardiac output, or the way that we describe cardiac function. Cardiac output is a way to quantify cardiac function. Now, what we'll be describing here has to do with the way that the heart does its job, but we're using a way of describing it that makes it objectively make sense to us. What's actually happening in the heart is really just it's doing its job, but we can quantify what's happening, we can break it down into different aspects. Just understand that things aren't ever as clean as this type of approach suggests. So take a lot of this sort of approach with a grain of salt, so to speak. A mathematical or algebraic definition of cardiac output is that it's stroke volume times heart rate. Now remember, stroke volume is how much blood is ejected from the ventricle in one heartbeat, the difference between end diastolic volume and end systolic volume. And then heart rate is how many beats per minute the heart beats at. The general number that we work with in a course like this for stroke volume is 80 milliliters per beat, and heart rate would be, at rest, 75 beats per minute. So if we multiply those out, we get 6,000 milliliters per minute. The beats in both units cancel out, so it's milliliters per minute. 6,000 or 6 liters represents, coincidentally, about the same as the average volume of blood in the body. There's nothing cosmic about that connection, it just happens to be about how much is moving through. Now what's important about cardiac output is that it changes. There's resting cardiac output, which is basically what the numbers I just gave you represent, and there's a maximal cardiac output that's possible, and the difference between those is the cardiac reserve. So we can do things to change cardiac output by altering stroke volume and heart rate. So just imagine simply the heart rate goes up to 100 beats per minute. That's going to make cardiac output go up from 6 liters per minute to 8 liters per minute. Okay, just that little change right there. This summary figure puts those ideas together. Heart rate times stroke volume equals cardiac output, and even more so, stroke volume is the difference between the end diastolic volume and the end systolic volume. There are also lists of things that affect heart rate and stroke volume. Heart rate is largely under autonomic innervation. Parasympathetic slows things down, sympathetic speed things up. There are also hormones that can play a part, whether it's thyroid hormones or those sorts of things. They can contribute to what's happening in the heart for the heart rate. And then as somebody is more and more fit, then the resting heart rate's going to change, and as age increases, the maximal heart rate will drop. The rule of thumb for that is 220 beats per minute 220 beats per minute minus your age. So somebody who's 20 years old would have theoretically a maximal heart rate of 200 beats per minute. Somebody who's 40 would have 180 beats per minute. Somebody who's 60, so on and so forth. We'll talk about the autonomic innervation aspect of things and hormones when we look at the regulation of all of this in the next section. For factors affecting stroke volume, there's a number of things here. Fitness level also has a role to play, as well as the physical size of the heart, gender, those sorts of things. We're going to look specifically at some of the other ones here, preload, contractility, afterload, to understand a little bit more of how we modify stroke volume in homeostatic mechanisms. To look at how we regulate stroke volume in the body, we're going to consider 3 of the items that were listed in the previous summary figure: preload, contractility, and afterload. Preload is a characteristic of muscle in general. It applies to skeletal muscle and cardiac muscle. When we consider it in terms of cardiac muscle, it has a specific name, which is the Frank-Starling law. But really all it is that the more you stretch the sarcomere structure of one of those types of muscles up to a point, then the better contraction you can get. So imagine the overlapping thick and thin filaments. At rest in a relaxed muscle, there's a little bit of overlap there. If you stretch it out to the edge of where they're still overlapping, then that gives you more region to actually contract the muscle in. Now, within limits, you can increase the contraction by stretching out the muscle. As soon as the thin and thick filaments are no longer actually overlapping, you don't get any contraction. There's no way for myosin and actin to interact. Now, for cardiac muscle, the way this is done is by putting more blood volume into the ventricle. Okay, so just like a water balloon, you would stretch out the walls of the ventricles a little bit. Up to a point, that'll increase the contraction possibilities of the muscle, which means specifically this is increasing the end diastolic volume, which is therefore going to increase stroke volume because the difference between end diastolic volume and systolic volume will be greater. To consider this idea, let me use an example from skeletal muscle. So here we have two pictures of people throwing a pitch. The first picture is of presumably an Olympic softball player. I assume that's why it's Team USA. The picture is actually a little bit into the pitch, but you can imagine certainly that she would have had her arm stretched far back behind her, winding up for the pitch at some point. And then we have the other person doing a ceremonial throwing out of the first ball at some sort of baseball game. And you can tell from the way that she's holding the ball that she didn't wind up. She's just throwing it from the elbow, basically. And the difference in the speed and the force you're going to get behind these two pitches is vastly different. And that's because of preload. By stretching out the muscles of the arm, the biceps brachii, during the windup of the pitch, able to get more force out of the throw. Contractility is a look at how well the muscle contracts, how much force it can generate during contraction. Now, in talking about preload, it was said that by stretching the muscle out a little bit, you can get more contraction. And that's really more about the distance along which the thin filaments slide over the thick filaments. Contractility is more about what's happening with the myosin heads moving and the interaction between all of those muscle proteins in the sarcomere. It's a calcium-dependent process. It's more forceful contraction on top of what the muscle can do on its own. And it really is just about calcium influx. Now, here we see two bullet points that are positive inotropic factors and negative inotropic factors. Inotropic is referring to the ability to make the cardiac muscle contract. And so positive inotropic factors are those that increase contractility. And it's anything that's going to increase the influx of calcium ions. For cardiac muscle tissue, remember, calcium ion influx is a bigger player than it is in skeletal muscle. In skeletal muscle, the membrane potential is changed mostly by the movement of sodium and potassium ions. But in cardiac muscle, there's an influx of calcium ions also, which plays a big part in making contractility possible. And the more that that's increased, the more contractility that you're going to have. Two players in increasing contractility are epinephrine and thyroxine. Epinephrine is the hormone that's released as part of the sympathetic response from the adrenal medulla. And by saying epinephrine has an effect, norepinephrine would also, which would be released from postganglionic sympathetic fibers. Thyroxine is one of the thyroid hormones. It's T4, and it increases the contractility of cardiac muscle also. Now, negative inotropic factors are those that decrease contractility, and anything that increases extracellular potassium is going to have that effect by interfering with the concentration of the various ions in the extracellular fluid. And then anything that blocks calcium channels directly is going to have a negative ionotropic effect. Now, extracellular potassium levels is actually the mechanism that lethal injection as a form of capital punishment works through. And so there, negative inotropic factors are quite severe. Calcium channel blockers are less severe, and they're actually used in a number of situations to reduce the activity in the heart when that's necessary. I think if somebody's having a heart attack or something like that, or at risk of having a heart attack, they might take calcium channel blockers as a matter of course. So there are some pharmaceutical therapeutic reasons for negative inotropic factors to be used beyond just the simple lethal injection approach that is really about the potassium there. Afterload is the pressure that's on the other side of the semilunar valve that has to be overcome before the ventricle can eject blood. Now, the word sounds similar to preload, but they're very, very different concepts. They're not related whatsoever. Now, if the pressure in the aorta, for instance, is 135 millimeters of mercury, then the pressure in the ventricle has to build up to that level before it can even open the aortic valve, which is going to compromise how much can be ejected from the ventricle in that time period. There's not really a way to regulate afterload. More, it's a negative effect on cardiac output. If there's an acute change in blood pressure, if it goes up suddenly for a little bit, then we do have ways of regulating that. But chronic high blood pressure ends up becoming the standard for the system. Your body will adapt to that, and therefore afterload is just a problem that somebody has to put up with, which is why high blood pressure is a risk factor for heart disease, that it's pushing the heart to work harder just to get blood out and around the body. This summary table lays out these three major factors affecting stroke volume and explains where they come from. So it's looking at both what happens when stroke volume is increased as well as when stroke volume is decreased and the various players that have an effect on that. Consider this question. When you feel that you've reached an answer, hit the next button to go into the next slide, which will reveal the correct answer. So, like I said, afterload is the pressure that's found in the aorta, for instance, on the left side, that the ventricle has to overcome to push the blood out, to eject it out. There are some acute changes that can be affected under homeostatic control, but chronic blood pressure, which is really the contributing factor most often to afterload, can't be controlled homeostatically. The body will set that as the correct blood pressure, even though it's hypertensive, but the body will just adapt to that, and there will always be an afterload problem. Now, to just point this out, I've given 4 answer choices, as I usually do in these questions, and D here, heart rate, is not an aspect of stroke volume. It's an aspect of cardiac output, but it's the other side of things. But I needed a 4th in the answer choices here.